Good morning. Welcome to this morning session. I am Giacomo Grasselli from Milan, and I have the pleasure to chair this session together with my friend and colleague Tommaso Mauri, who works with me in Milan, actually. We have I have to say, a fantastic panel of speakers this morning to discuss about pathophysiology of respiratory failure. So the first speaker is Professor Wundering from Northwestern University, Chicago. He did a long trip to come here in these difficult times. So thanks, Professor Wundering.
Thank you. Thank you to the organizers for inviting me to come back. And let me talk a little bit about our research in COVID-19. My conflict of interest is mainly with the grant that I'll be talking about, and also with a company that we're working with on a clinical trial. In what we tried to understand is severe SARS-CoV-2 pneumonia different than other viral pneumonias? And is the ARDS from severe SARS-CoV-2 pneumonia different than other forms of ARDS? And so a lot of this was based on some of the challenges that we saw in the literature. Analysis of blood samples may not truly reflect what is going on in the lung, which is really the only major site of infection in SARS-CoV-2. And autopsy studies likely reflect later stages of disease and therefore may not give insight into the initial pathogenesis. And so we had concerns about what was in the literature at that time. Distinguishing the effects of infection from the effects or the results of therapy is also very difficult and continues to be a challenge. And then these are critically ill patients, so they're going to suffer the same complications that all critically ill patients do that are mechanically ventilated, and that's also likely to impact the analysis. And so this was a real challenge to try and understand the pathophysiology. We were actually helped by the fact that we already had a large NIH systems biology grant that was in place at the time when COVID-19 hit. And the major emphasis of this grant was to actually get serial BAL samples from our critically ill patients suspected of having pneumonia, and doing a variety of multi-omics on both the host side of things, so flow cytometry and cell sorting of our BAL, transcriptomics, epigenomics, and also looking at the originally bacterial side of things with not only culture but shotgun microbiome, bacterial genomes. And then data management and modeling. And so this was in place when the SARS-CoV-2 pneumonia pandemic hit, and so we fairly quickly adapted this to study SARS-CoV-2, resulting in a paper published in Nature this year that I'm going to go through in a little bit of some of the findings that we had from this particular analysis. Now, I'll emphasize that this is mainly from the first wave of SARS-CoV-2 in the Chicago area. A little bit about the cohort and demographics. These are ventilated patients. Because of this prior grant, not only did we have COVID-19 pneumonia patients, but we had other viral pneumonia patients. We had multiple bacterial or fungal pneumonia patients, but we also had ventilated patients without pneumonia, so a non-pneumonia control. And for a few analyses, we had some BALs from healthy controls. And just a little bit about the demographics. The SOFA scores were relatively high, but not distinguishing between those groups, and I'll try to keep the SARS-CoV-2 patients designated by red throughout this in the other viral pneumonias in green. What we did see is that in our cohort, the mortality was actually less with SARS-CoV-2 than with other viral pneumonias, other pneumonias itself. However, the length of stay and the duration of ventilation are clearly much longer than these other causes of respiratory failure. We did not systematically look at peripheral blood for our script grant, but there was blood available, so you can see CPK was a little bit elevated. CRP is clearly elevated in SARS-CoV-2 compared to other viral pneumonias, or other pneumonias or controls. We had very few CRPs. That's not a standard test in our institution. D-dimer was actually less than it was for viral pneumonias and bacterial pneumonias. Ferritin was high, but same as other viral pneumonias. LDH was a little bit elevated, and procalcitonin was actually on the low side compared to other viral pneumonias, and other viral pneumonias were disproportionately influenza. So, but not that different than most of the reported literature. One of the first things that we noticed as clinicians taking care of the SARS-CoV-2 patients is that there was a lymphocytic alveolitis. This is just an early analysis. The red is lymphocytes, and these are patients suspected of having bacterial pneumonia for the most part, and what we're seeing is very few neutrophils. There is a somewhat inverse relationship here between PMNs and lymphocytes. In our prior BALs, the upper 95% confidence interval for percent lymphocytes was about 10%. And so you can see that at the bottom there that many of these patients had significantly higher lymphocytes than what we were used to seeing. That was the first clue that there was something different going on in SARS-CoV-2. The other thing is monocytes are a lot more common. Some of the missing percentages are we saw plasma cells and BAL fluid, something that we hadn't seen before. Occasionally eosinophils in relationship to hypersensitivity pneumonitis, usually to tocilizumab. So the BAL by itself was very interesting. Our pathologists who were actually looking at this were also surprised. They could tell who was SARS-CoV-2 because they were seeing very unusual lymphocytes. So at the very bottom with the single arrow down here is what a normal lymphocyte would look like in BAL. And what they were seeing is these very activated lymphocytes that were very common, and also increased monocytes, as you can see in the lower left corner there, which was very unusual for our typical BALs. And so our pathologists could actually tell which patients had SARS-CoV-2 almost as fast as they could get it with the PCR. And this has been reported. This is just one study that showed the lymphocytic inflammation in an autopsy patient, showing that this is not an isolated finding. That was our clinical differentials. This was confirmed by flow cytometry. I'm going to take a minute to walk through this a little bit. So we used hierarchical clustering here to determine how these samples were grouped together. Once again, the SARS-CoV-2 is in red here, and then the non-pneumonia controls, light blue, other pneumonias, dark blue, and other viral pneumonias in green. And what you can see by this hierarchical clustering was what I was talking about before, that actually neutrophils were increased in most of our other BALs, but were actually decreased in the patients who had SARS-CoV-2. In contrast, here we're seeing that both CD4 and CD8 lymphocytes were increased in our BALs, and also monocytes, probably the strongest signal here of being somewhat different than other types of pneumonia. In our alveolar macrophages, there was a somewhat decrease in the resident alveolar macrophages, if you accept a low CD206 as evidence of that, and increased in the CD206 high alveolar macrophages, so monocyte-derived macrophages. And this is just the graphic of that. And so we're seeing increased or relative decrease in neutrophils, a relative decrease in the CD206 high macrophages, and then the increase in CD4 and CD8 T cells, and specifically monocytes. So these were unusual patterns compared to our normal. When we did bulk RNA-seq on the macrophages, we also saw that there were different patterns here. And once again, this is hierarchical clustering. Now the patients with SARS-CoV-2 cluster a little bit closer together when you look at actually what's happening with the macrophage repertoire. And what we saw is that there are clusters of genes that were increased, as noted by the more reddish hue, versus decreased in the more bluish hue. And so these two clusters, the top one had fairly characteristic like CCL24, and the GO analysis suggested this is type 1 interferon signaling pathway, interferon gamma mediated signaling, and that was very strongly expressed in our macrophages. The second cluster was more with macrophage migration and macrophage activation, and this was more characteristic in the SARS-CoV-2 patients than in other types of pneumonia, including other viral pneumonias. And this type 1 interferon pathway gene expression did decrease over time of mechanical ventilation, but there were wide confidence intervals, same thing with the average interferon gamma pathway. So the type 1 pathway was less prominent than the gamma interferon pathways in our patients here. And so because our flow cytometry lab was shut down for a while because of having to prepare it for SARS-CoV-2 and BSL-2 requirements, we had already started to think about doing single-cell transcriptomics. We had developed a way to save our cells, save our BAL samples for single-cell transcriptomics, and we're able to do that on our SARS-CoV-2 patients for this analysis. And this was actually gave us a lot of insight as well into the pathogenesis. So this is a t-SNE plot of each of the cells from BAL, and using markers, you can break them down into the actual cell types. And so I'll point out a couple of areas. These are monocyte-derived alveolar macrophages, and we were able to find 3 different patterns here. These are tissue-resident alveolar macrophages, and we were able to break them down into 2 different groups. This is a little bit of the analysis showing that there are very different transcriptomic patterns in the 3 monocyte-derived and 2 tissue-resident alveolar macrophages. The T cells localize here. We have a few AT2 and AT1 cells that we get in our lavages. A dirty lavage has more ciliated cells and basal cells from the airways, and then we have dendritic cells. And so the single-cell transcriptomics was a fascinating analysis of this. And so I'm going to show you a little bit more data from the single cell here. And the first is that SARS-CoV-2 can infect macrophages and monocytes. This was not thought to be true at the beginning of the SARS-CoV-2 pandemic. Here's this monocyte-derived alveolar macrophage group 1, or type 1, and tissue-resident alveolar macrophage type 2. And these are the infected cells here. So I'll have you kind of keep track of these areas. And not surprisingly, the biggest uptake of SARS-CoV-2 genes were in the alveolar epithelial cells and some in dendritic cells. And we were not only able to find the sense RNA, but the antisense RNA, and we were actually able to find the entire SARS-CoV-2 genome within alveolar macrophages. And on this plot, you can see that the duration of ability to find SARS-CoV-2 in macrophages actually extended out, in some cases, extremely far, so 40 days of mechanical ventilation. And so we think that that's part of the pathogenesis as well, that they have residual or persistent viral infection. Now, here's a few genes of interest here. So in the middle plot here is the SARS-CoV-2, so you can keep track of which are the infected cells. And we get some CCL20 from the tissue-resident macrophages. Interferon gamma is coming from the T cells. CCL4 is disproportionately coming from the infected monocyte-derived and tissue-resident macrophages, as well as T cells. IL-1 beta, and then an interferon gamma response score taking care of, or taking into account multiple transcripts is clearly increased in all populations. And one of the second major findings is that it was unclear where the high serum IL-6 levels were coming from. There was a theory that it was coming from the alveoli and the alveolar macrophages specifically. And what you can see here, this is a log scale, but in fact the SARS-CoV-2 patients did not have higher IL-6 transcripts than viral pneumonia or even bacterial pneumonias, or even non-pneumonia control. These are critically ill patients, but all of these populations had more IL-6 than healthy controls. So the increased IL-6 is not coming from the lungs itself, even though there are high levels. Now, this is probably the most interesting presentation of our data. Here, rather than the hierarchical clustering, we actually analyzed by diagnosis, so all the red is the SARS-CoV-2 infected patients. Here's other viral pneumonias. And this part of the graph is we organized by day of mechanical ventilation. So the black here is the initial within 48 hours of being intubated, and then progressively as the purple gets darker and darker, it's later and later in the stage of or duration of mechanical ventilation. And the red bars here indicate when we were able to detect a bacterial copathogen. And what you can see here, and this is the same percent neutrophils, macrophages, monocytes, and lymphocytes, is that there are some patients and some samples that had persistence of this increased T cells going way out, and that the monocytes were increased early on in the disease, and that a progressive or persistent decrease in these CDC206 high macrophages. And so I think the insights that we got about SARS-CoV-2 pneumonia is that this is predominantly a lymphocytic alveolitis, a striking lack of neutrophil infiltration compared to other types of pneumonia, including other viral pneumonias. The peripheral lymphopenia is, we think, an artifact. There's lots of lymphocytes in the BAL at the site of infection. We did have about 20% initial bacterial pneumonia at the time of intubation with some other data. SARS-CoV-2 can clearly infect macrophages and monocytes, and we see this depletion of tissue-resident alveolar macrophages as the part of the pathogenesis. And then it generates a gamma interferon response, minimal type 1 interferons, and it results in these self-sustaining circuits between infected alveolar macrophages and T cells, and resulting in prolonged rather than higher cytokine production. And the model that we put together for this was that if this is the normal alveolar space, SARS-CoV-2 infects the AT2 cells that do have ACE receptors, but there also infects the tissue-resident alveolar macrophages, which do not have the ACE receptors. These infected monocytes attract the T cells. They are CoV-2 reactive, whether that's because of the duration of infection prior to intubation or whether they have some cross-reactivity, generating a significant gamma interferon response. Ultimately, these tissue-resident alveolar macrophages die, but there's this ongoing recruitment of monocytes into the lung, differentiation into alveolar macrophages, and an ongoing gamma interferon response. And this cycle continues with infected monocyte-derived macrophages now dying and continuing this circuit, maybe even migration from one alveolus to another alveolus as a way of this slowly progressive disease. And so there are lots of unanswered questions that probably the biggest ones are what are the determinants of recovery versus not, and we're working on that analysis. Do interventions affect this alveolar milieu? This was, as I said, our first wave. We were not using steroids. There was a fair amount of anti-IL-6 therapy given during that time. And most importantly, can we focus on alternative interventions based on this pathogenesis? I'll thank all the huge number of people that contributed to this work, and happy to answer any questions.
Thank you very much. We have time only for one quick question from the audience, or?
I have a question. You showed that this alternative pattern of immunoactivation in COVID leads to prolonged inflammation, but maybe less severe, because I was impressed in the first slides you show that these patients have long length of stay, long ventilation days, but lower mortality compared to your control group of pneumonia. So if you have this self-sustaining pattern, but kind of less severe, you think it's a good idea to use steroids in all patients early in the course of this pattern?
Yeah, so that's a question that we're trying to answer right now because, as I said, this was the first wave. We had a low mortality, and once the recovery study was published, everybody got steroids, and our mortality went up. Now, probably the most likely explanation is that steroids prevented patients from being intubated, and the ones who failed now may be a different type of population. Our preliminary analysis also shows that the percent lymphocytes also go down, and so we're seeing a reemergence of neutrophils in steroid-treated patients. So the cause and effect relationship there is unclear, but we have not seen a significant benefit from the routine use of dexamethasone in our patients.
Thank you. We move to the next speaker, Professor Paolo Pelosi from Genova, speaking on the complex relation between lung aeration and perfusion in COVID-19.
Thank you so much, and now we'll discuss a little bit some physiological aspects related to the gas exchange, and this is the result of a large multidisciplinary team in our hospital, including, of course, anesthesiology intensivist, infectivologist, pneumologist, and anatomopathologist, together with the support of the radiology department and from colleagues from the United States and Pennsylvania for specific analysis of regional distribution of perfusion, as well as colleagues from Brazil. We will try to discuss a little bit the darker side of the moon. You know that gas exchange is related to aeration or ventilation and perfusion, and the better knowledge of aeration-perfusion relationship might help to better individualize and personalize therapeutic management. This is just to summarize the relationship between aeration and perfusion. This is a normal alveoli, in a model with FR2 50% and fixed hemoglobin and respiratory quotient. We have cases in which we have a reduction in the ventilation, and this might promote an increase in PCO2 in the alveoli and a reduction in PO2, and this is the low VAQ ratio. And in these areas, if we give oxygen, we might increase oxygenation. And then we have always to reminder around 3 to 5% of anatomical shunt. At the extreme of that, we have the true shunt, in which we have no ventilation, and all the blood is not oxygenated. This is so-called venous admixture, which is the sum of the low VAQ areas and the true shunt. On the other side, we can have areas of the lung where we have high VAQ ratio, which on the extreme is the dead space, where we have no perfusion but aeration with a sort of anatomical shunt. And this is the so-called wasted ventilation, which includes the high VAQ areas and the dead space. Overall, this is the typical representation of the different pattern and distribution of the VAQ areas. And from one extreme, we have the shunt. On the other extreme, we have the dead space. And again, the venous admixture and wasted ventilation. This is what we try to reproduce in vivo in COVID-19 patients. We know that perfusion and Aeration and Perfusion may be affected by different factors, by vasoconstriction, hypoxia vasoconstriction, swelling of the endothelial cells, obstruction or microthrombosis, and collapse, mainly in the most dependent part of the lung. The air repression and posture, like prone position or beach chair, might affect regional distribution. And this is a typical distribution of perfusion in traditional RDS. In red is more blood perfusion. You see most of patients, they have a gravitational distribution of perfusion, more in the dependent part of the lung in red, where we have more densities. So actually, we have a relationship between oxygenation and the proportion of oxygen and the fractional water higher than 0.7, so higher density. So in traditional RDS, in the dependent lung region, we have consolidation and most often atelectasis with a gravitational distribution of regional perfusion. So hypoxia is mainly due, at least 80%, due to the true shunt. We look at the anatomopathology of COVID-19 patient by a particular technique which used the cryobiopsy. So we performed a fibroscopy in patients who died within 20 minutes. This 20 minutes is the time required in Italy for declaration of death. And during mechanical ventilation, we sampled different areas of the lung. This is totally different from autoptic study, in which, of course, the analysis is performed days after the death. So we found different patterns, and we related to the CT scan just to understand better how is the lung in COVID-19, at least in patients who died. This is the relatively aerated areas. You see the alveoli. In the black areas, you see the epithelial cells completely altered. And in the red arrow, some hyaline membrane, but not much edema within the alveoli. The so-called ground glass areas, you see an initial alteration in the vasculature and in the alveolar size, with some areas of fibrosis and some microthrombosis, not too much in our analysis. The white areas are characterized by the complete derangement of the vascular side, so you don't see any more of the vessels. This makes some discussion if it is only a problem of microthrombosis. We found a complete alteration in the vascular side, so complete necrosis of the lung. And the honeycombing, specifically, particularly located in the peripheral areas, And these are characterized, you see in the blue box, by mucosinosis in the alveoli, so gelatinous material in the alveoli, not edema. And next, you see the interstitium, very thick interstitium, and the red cells, these are smooth muscle cells, which show the complete deregularization of the fibrotic process in COVID-19. So we found pneumolysis, vascular lysis, complete necrosis of the lung, alveolar cell infiltration, alveolar mucosinosis, and fibrosis, mainly in the late and mid-day pattern. So we perform CT scan in many patients at fixed PEEP, and we identify mainly two phenotypes. Really, there are three, but to simplify, two. So what we call phenotype 1, so multiple focal overperfused ground glass opacities, and phenotype 2, more similar to the typical RDS, even if it's not. These patients were mainly treated by non-invasive respiratory support, while these patients were mainly required intubation. So what we found is that in normal lungs, the lung weight is around 800 grams. The traditional RDS patients, they have a lung weight of around 1 kilo, 800 grams. And the excess tissue mass is around 1 kilo. In phenotype 1, the lung weight is not so much increased, it's around 300 grams more as compared to normal subjects, while in phenotype 3, the lung weight is a little bit less than traditional RDS, 1 kilo 600, with an excess tissue mass of around 800 grams. So the question is if it is the quality of the excess tissue mass is the same or not. So it's due to the edema or it's due to a necrotic consolidation process. So we performed the dual energy blood volume computed tomography, which is based to two different amount of energy in the, given to the lung by a rotating tube. And this is based on the concept that according to the photoelectric mechanism, you see that with iodine, if you give two a different voltage, you have different absorption in terms of in the lung. So it's possible to see changes in the densities related to two different amount of energy, and this allows a more specific detection of peripheral blood volume distribution, which is associated with perfusion. Different studies showed that the distribution of blood volume is associated with perfusion. And the voxel here, as if in a normal CT scan is around 22 millimeter cube, while here is 1/4, so 5 millimeter cube. So it's very, very specific, both for density, both for perfusion. So this is the first case that we did, and this is the images. You have this CT scan, very specific, because I remind you, every voxel is 1/4 compared to the traditional voxel. So it's like a sort of high-resolution CT. It is even more specific, the high-resolution CT. And the other side, you have perfusion, and you can reconstruct in 3-dimensional. So the whole lung is matched for aeration and blood volume, the whole lung, not only one part of the lung. And this is one of the first studies in which we look at the patients who were in non-invasive respiratory support and were not intubated, and those patients who require mechanical ventilation. This is the distribution of normally aerated, non-aerated, and poorly aerated lung areas, and they follow a traditional distribution from non-dependent to the dependent lung region, but the regional blood volume distribution is anti-gravitational. This is different from traditional RDS. We have more blood flow in the non-dependent part of the lung, and this is similar in non-invasive and invasive mechanically ventilated patients. So the distribution of aeration is a similar pattern to the traditional RDS, with some difference from non-invasive to invasive, but most important, the distribution perfusion is anti-gravitational, so we have more perfusion in more aerated lungs, So this is protecting the increased shunt in the dependent part of the lung, and on the other side, decreases the low VQ in the aerated lung because we have more perfusion than you expect. So we were able to reconstruct a so-called gas-blood ratio. This is like the Wagner distribution. In that case was ventilation. In that case is aeration, because we did not measure aeration. But at the PEEP level that we measured, which was 8 centimeters of water, the distribution of ventilation is reflecting the distribution of aeration, okay? And so we were able to measure in all the conditions the different pattern of the VQ, low and high VQ areas. This is the distribution from ventral to dorsal, and you see that mainly in the ventral areas, almost 70% of the lung is characterized by dead space and high VQ, which is reduced in the lower part. Overall, it's around 40% low VQ areas. The areas with, so high VQ areas, sorry, and dead space. The low VQ is homogeneously distributed, while the amount of shunt is progressively increasing in red, of course, from non-dependent to the dependent part. In black are the areas non-aerated, non-perfused. And you see that especially in the dependent part, at least 1/4 of the shunt is protected by non-perfusion. So non-perfusion, microthrombosis or necrosis might be partially protective in terms to prevent further deterioration in gas exchange. And this is the same when you look at the apical to caudal distribution. So if you have two phenotypes, and then we compare the normally aerated lung tissue with the PO2-FO2 ratio, you see that we found a very good correlation. So PO2-FO2 may predict the amount of normally aerated lung tissue. As well, much less the poorly aerated, and very well correlated with non-aerated. Overall, the gas mismatch, including all components of gas exchange, were correlated with PO2-FO2. And when we look at the independent factor of the VQ distribution, we found the PO2-FO2 was mainly, the main determinant was the true shunt, not the other components. So oxygenation is a very good indicator of the progressive deterioration of the disease in these patients. So when we look at the total lung mass, you see here again, we found difference between non-invasive and invasive mechanical ventilation. So during invasive mechanical ventilation, we found a reduction in normally aerated tissue, a little bit increase in poorly aerated, but much higher increase, of course, in non-aerated lung tissue. More interestingly, when we look at the distribution of gas exchange, you see that the patients who were maintained in non-invasive respiratory support, so were not intubated, they did not present a major difference in dead space or high VQ areas, which is high anyway. Almost, you see, around on average 40% in the overall lung. While the amount of gas-blood ratio below 1 was higher in patients who maintained a non-invasive respiratory support. While patients who required intubation, they had a higher amount of shunt, partially protected by non-perfusion. So this is, to me, is very clear model. So in those patients in which high VQ is predominant, these are the patients who respond better to non-invasive respiratory support and high FiO2, while those patients who have shunt, they require intubation. So this is our model. So the COVID-19 is very likely to be like a primary RDS, with pneumonia and vascular lysis, with gas volume substituted by cellular necrosis, cellular infiltration, and fibrosis. We did not find not much edema in this patient, even if biopsy, of course, were performed in patients who died later. We have very few patients who died early. Consolidation with higher perfusion in non-dependent lung region, with poor and no recruitment with high PEEP and prone, but this is another topic, with the response in oxygenation associated with a distribution of perfusion, but not better aeration in terms of recruitment. So we have hypoxia, with low lung weight, low lung recruitability, high compliance, and low inspiratory effort, in which high vasoconstriction mixture is mainly due to low VQ, in the poorly aerated tissue, and less through shunt. Of course, high wasted ventilation anyway. These patients have a good response to higher FiO2 and non-invasive respiratory support. Patients with what we called unhappy hypoxia are characterized by higher increase in the lung weight, low recruitability anyway, low compliance with high inspiratory effort and increased dyspnea, and high vasoconstriction mixture was mainly due to true shunt and less to low VQ RS. Of course, again, high level of amount of high wasted ventilation. In these patients, we have anyway poor oxygenation response to higher FiO2, and this patient require intubation. So we move from happy hypoxia phenotype 1, in which we can use high flow, CPAP, or positive pressure non-invasive ventilation, to unhappy hypoxia phenotype 2, which require intubation. So these are my conclusion here, and our conclusion from the team. In critically ill patient, phenotype 2 is more frequent than phenotype 1 in COVID-19. We found an inhomogeneous pattern of aeration, blood volume distribution, as well as perfusion defect. Pulmonary pattern, blood volume, and perfusion defects were associated with clinical outcome, inflammatory, and thrombophilia markers. I have not specific time to show all these correlation. The model is quite clear from our point of view, with hypoxia characterized by higher compliance and low effort, and low VQ, much less importance in the low true shunt, anyway with high VQ RS, and most responsive to FiO2, and unhappy hypoxia, which are characterized by higher lung weight, lower compliance, and higher amount of shunt, which in our opinion requires prompt intubation. Thank you very much.
Thank you. Any question? You can come here. No, there is a microphone there.
Thank you, Paolo. This was a very, very interesting presentation. All these differentiation between phenotypes and type 1, type 2, first of all, could you conclude, would you agree that COVID-19 ARDS is basically ARDS due to pneumonia as opposed to extrapulmonary ARDS? And the other point is, type 1, type 2, is this just differences in severity or differences in evolution of the disease, from low degree of severity to high degree of severity?
Yes, I mean, this, I agree with you. In our opinion, from anatomopathological data from our team and the response in terms of PEEP and this aeration blood volume distribution might be classified, in my opinion, as this is the typical primary ARDS that we had not seen before, because you remember when we tried to classify primary and extrapulmonary, primary were associated with sepsis. COVID, in my opinion, is a quite experimental setting. This is not a good word because we know how many patients died and suffered for this disease, but without sepsis at the beginning. They don't require vasoactive drugs except for due to the sedation in most of cases. Then they develop sepsis, but as a super infection. And the second issue, we try to simplify, but this has not to be, I agree, I mean, this is an evolution of the disease. So you can move from mainly phenotype 1 to phenotype, are not two different patterns, are the extreme of the same pattern, yes. This is interesting, but this is another issue when you move, when you go back from the what's simplified phenotype 2 to phenotype 1 and in the so-called resolution problem. We have data suggesting, again, from anatomopathology, that at the CT scan, when you look at the alteration, even after extubation, you cannot predict from the CT scan. Some, they have a lot of collagen, others have not. So don't use a CT scan to predict if the patient will go well or not, because some have more collagen, others have less collagen. So it's more complex than we believe.
Yeah. Paolo, thank you very much. I like your concept with the two phenotypes very much. And also the concept that phenotype 1 is more prone for non-invasive ventilation and type 2 for invasive. In Germany, we observed in the first wave only very few patients with non-invasive ventilation, and then in the second and third wave, it increased very much, the usage of NIV. And after a few days, let's say 5 to 10 days, we saw many patients with very stiff lungs after NIV. So for me, the major question is, how do you observe that you have a transition from phenotype 1 to 2, and that comes to the point, when is the right point to intubate these patients?
Yes, thank you very much. Of course, I tried to cover just the physiology today. Then we have, of course, we publish also the data clinic and respond to your question. We have another study in which we look at the effect by the CT scan of patients who had longer period of non-invasive compared to shorter. And if there may be difficulty in the interpretation, but we found that patients who required intubation, so they did not improve, after more than 2 days of non-invasive respiratory support, they presented more damage in the lung. So we believe that patient self-inflicted lung injury really exists, and especially in COVID, but this is not due to the traditional concept. We did not find an increase in recruitment in these patients. So this means that the lung has a major necrotizing process. So the process of the lesion in COVID-19 is a little bit different from the patient safety in the traditional, where we have the lesion of the alveolar capillary barrier. You have here the lesion plus the complete disorganization of the system. Which is the parameter? There are different, but I show you that at least this physiological study showed that oxygenation is very important. Then, of course, respiratory rate, we know the transformative rate, whatever we can use. Now, for example, we have a study in which we look at the airway swings in the nose compared to the esophageal swings, and they are very well correlated. But this is in general, not only COVID, was done in COVID. So we can have different parameters. But my message here is that, as always, gas exchange and especially oxygenation is a very important. So if a patient is deteriorating oxygenation, in our opinion, if possible, it's better not to prolong non-invasive respiratory support and intubate early.
So thank you, Paolo. Thanks. So now we move on to the next speaker, who is our mentor, Professor Antonio Pesenti from Milan. And I think that he will continue the discussion on gas exchanges in COVID-19. Antonio.
Thank you. I am afraid I have much simpler data than Paolo presented. Sorry. First of all, I will not talk about hypoxia or hypoxemia because you can, but I found this paper from Tobin very, very informative and very stimulating. I suggest you all read it because Tobin is a very, very wise and detailed discussion. This is a comparison between ARDS patients from the LungSafe all around the world. That it was conducted in 2015, 2014, and published in 2016. And you see that our COVID-19 patients and LungSafe did not have a very different FiO2. They did not have a very different PO2 FiO2, slightly lower PF ratio, and slightly higher PEEP. Keep in mind that in the LungSafe, we noticed that PEEP were slightly lower than recommended. But basically, I think that the fact is that these COVID-19 patients had possibly a slightly more severe ARDS than the average lung-safe patient. And once again, this usual story, hypoxia is caused by true shunt, mainly in ARDS. And this is an original paper from Dansker, I guess, or yeah, Dansker, showing that the distribution of VQ is not very broad, but we have, in this patient, 30% true shunt and 18% dead space. The problem of the low ventilation perfusion areas is more complicated. Areas with low ventilation compared to perfusion generates a lower than ideal PO2 and a higher than ideal PCO2. So here, these are different patients, two different patients with regions of low VAQ. Now, in the discussion of this, point is that the effect of low VAQ should disappear as measured by venous admixture by increasing FiO2. And most ARDS patients have pretty high inspiratory PO2s. So we see sometimes described low VAQ areas, but their effect on arterial oxygenation and venous admixture is disputable given the FiO2 in use. Moreover, we know that low VAQ areas with the classical concept of ventilation, mind you, with the classical concept of ventilation, cannot stay open at high FiO2s because the blood that goes through takes away more oxygen than we put in with the ventilation. And so the alveoli are going to collapse. And this has been shown many times. This is in normal subject and anesthesia. When the patient is ventilated with 40% oxygen, at induction we see airway collapses at the bottom of the lung. Recruitment maneuver, and then if you go on with anesthesia at 40%, the lung stays open. At 100%, you have more collapse. You do a recruitment maneuver, the collapse disappears, but then it comes back because with high FiO2s, the tendency to collapse is much higher. And this has been shown in ARDS too by Rodriguez-Rosen as an example, or by Laurent Brochard. Increasing FiO2 increases the measured shunt. So what these low VAQ areas are really, in truth, we don't know exactly. Perhaps is fluids or bronchiolar closure rather than alveolar collapse. But anyway, I am not able to discuss that point. I just show a difficulty in the model. Now, we see that these patients with COVID have very high dead spaces. First of all, since they have a high shunt, we have to keep in mind that shunt itself does not only cause hypoxemia, it also causes inefficient CO2 removal that we measure as dead space. And in this paper, this is an old paper in anesthesiology,
we see that if we have, according to the shunt, you can measure 50% more dead space than what is really present. But you can compute. These days, as opposed to 1965, we can make a little program and it compute it automatically. Point is that these patients with ARDS and with COVID ARDS both require high ventilations, 12, 13 liters per minute in average, which is 2 or 3 times the normal ventilation required by a normal subject. You see, this is again a comparison between lung-safe and COVID-19. And you see that in COVID-19 is slightly worse because PCO2 is slightly higher and minute ventilation is slightly higher. But COVID-19 patients, from the point of view of dead space, there is not a substantial difference between the two populations. Dead space is caused by ventilation of non-perfused regions. And we know since many years, this paper is 1981, 79, 81, the people in Boston published evidence of microvascular occlusion and vascular occlusion and arteriolar occlusion in ARDS. Then we all forgot somehow about it. But this is what leads to the need of very high minute ventilation in ARDS patients. We know also that vascular occlusion causes very low PO2s in the region that are not perfused, but ventilated. And this might damage the lung. This is the work that we actually, Tommaso Mauri led the group that doing the experiments of left pulmonary artery ligation, and we demonstrated that the left artery ligation causes ventilator-induced lung injury in the right lung without changing the total ventilation. And this effect is prevented if the animals breathe 5% CO2. See here the lung histological damage as an example in the ligation, in the control, and in ligation plus 5% CO2. And is more or less the same story with compliance and with the amount of non-aerated lung. What happens is that there is a physiological response that when a region is not perfused, acutely the ventilation of that region is decreased by constriction of the airways. So there is a mechanism of protection analogous to hypoxic vasoconstriction. When a region is not perfused, we have a constriction of the airways that decreases the ventilation. Apparently, that mechanism fades off in days. And while 5% CO2 maintains even ventilation. Even ventilation protects the right lung, the perfused lung, from ventilator-induced lung injury, in a way. And this is the macroscopical aspects of the lung of these pigs. This is the ligation group, you see bilateral damage, because we have a damage in the non-perfused lung, and the damage on the right lung caused by ventilator-induced lung injury that normally would not have damaged the twice as perfused lung. And then it can be protected by 5% CO2. But anyway, this is not the point of today. The point of today is that ARDS, and so much more, COVID ARDS is a microvascular disease, not just an alveolar disease. And the point I like to stress is that dead space in itself does not cause hypoxemia. Provided we do not have some strange mechanism of redistribution of blood flow. If the blood flow is redistributed so that the blood flow of the shunted regions, the blood flow of the collapsed regions is increased, then the shunt increases. And as a matter of fact, the mechanism by which pulmonary embolism or pulmonary microthrombosis generates hypoxemia, because that is a fact. The fact is that patients with pulmonary vascular occlusions very often are hypoxemic. But the mechanism is not completely clear. Somebody says micro-occlusion causes hypoxia, macroscopic occlusion does not. I'm not convinced that it's so crystal clear. We know that specifically in COVID-19, because it has been investigated in COVID-19, there are opening of vascular shunts between the right and the left circulation, demonstrated by microbubbles going to the brain, as an example, demonstrated by neoangiogenesis in the lung of COVID-19. But it's not so extraordinary. In cirrhosis, in liver failure, we have something that our surgeons and pneumologists call Apathopulmonary Syndrome, which disappears after liver transplantation. And that is due to opening of right to left shunting that, once again, have a mechanism that is not well known. What I'm trying to say is that there are mechanisms that we do not know that cause hypoxia with vascular occlusion or vascular dilation. Another important, very important point we often forget, and I don't know whether Luciano Gattinoni is in the room, but probably not, I don't see him. In the 70s, he taught me that when cardiac output increases, the shunt increases. And this is from Dansker, 1980, a plot between shunt, changes in shunt, and changes in cardiac output. It means that if we increase the cardiac output, by some mechanism, the measured shunt increases. And sometimes the shunt goes down just because the cardiac output goes down. One thing that is often said, I don't know whether it is true or not, is that it has been supposed that the perfusion of the collapsed areas increases in COVID-19. In this example, it's decreased. So even that is not totally clear. These are data from our patients showing the vascular occlusion in COVID-19 patients. And the conclusion is that the changes, gas exchange in COVID-19 is, particularly as in pulmonary ARDS, as an example, in pulmonary caused by pneumonia, is very similar to that. Plus a very common thrombotic evolution of the lung with a lot of dead space. Unfortunately, we have very few data about central hemodynamics in these patients. We have some, but there are not many data published. Thank you very much.
Questions? No. So, Antonio, do you think that we should, because we are now giving anticoagulant to basically all, the majority of the patients, but you know that there are studies showing that maybe full doses of heparin are not indicated in all the patients, so many centers are now changing their practice on that. On the other side, there are also people who administer thrombolysis in patients with refractory hypoxemia, even without documentation of major pulmonary embolism. Do you think that we should change our practice on?
I think the point there is probably once again the severity of the disease and the effect that you want to reach. First of all, you have to distinguish between prophylaxis and therapy. Green in the 80s used to use thrombolysis with thrombolytics in ARDS patients with decreases in pulmonary artery pressure and improvement in oxygenation. That has disappeared. It was a bit weird, you know, courageous as a treatment. But here it depends on, I think the use of heparin has to follow the severity of the disease. And prophylaxis, I think, should be prophylactic, as has been suggested, rather than therapeutic.
And just another very quick question. So in this picture, the use of VV ECMO, which changes the mixed venous oxygen saturation, further complicates the issue of, for example, hypoxic pulmonary vasoconstriction.
That is a statement or a question?
No, it's a question. I mean, because we
Well, it depends on the stage of the disease, because when the disease is very advanced, I think the hypoxic vasoconstriction is not at work anymore. So, and anyway, it's something that does not affect the evolution of the disease.
Thank you.
Thanks.
So we move to the next speaker, Leo Unks from Amsterdam, speaking about diaphragm injury. So we are a little late. We will take some of the break, but we will have definitely a break. Thank you, Leo.
Okay, thank you very much, Tommaso. It's a pleasure and honor to be here and to talk about diaphragm injury in COVID. So I don't have any conflicts of interest for this talk. And this is a paper that was published in Nature Medicine that described all kind of extrapulmonary manifestations of COVID. We all know that COVID is primarily a pulmonary infection, but we also learned in the last year that there are effects beyond the lung. And it's a very interesting paper, but I was a little bit disappointed. Because there was not a single word about the respiratory muscles or the diaphragm. And we all know that a lot of COVID patients get admitted to the ICU, and we know that critical illness has a profound impact on our most important inspiratory muscle, the diaphragm. This study, for instance, by Samir Jabber demonstrated that after like 3 to 4 days of controlled mechanical ventilation, the pressure generating capacity of the diaphragm has decreased by 25%, and other studies have shown that diaphragm weakness is associated with difficult weaning, ICU readmission, and mortality. And this slide summarizes the pathophysiology of critical illness-associated diaphragm weakness. As we all have learned, there is an important role for mechanical ventilation. High levels of assist, diaphragm inactivity may result in atrophy, and inadequate support by mechanical ventilation may induce load-induced injury of the diaphragm. But there are other factors at play. For instance, denutrition, inflammation, sepsis, that all may play a role in development of diaphragm weakness in the ventilated patients. So these are some data from our own lab. In general ICU patients, we have demonstrated that there is development of diaphragm atrophy, what others have shown as well, and we found evidence for inflammation infiltration with macrophages, neutrophils, and other inflammatory cells in the diaphragm of critically ill patients. Also, at the ultrastructural level, so this is a more or less healthy subject diaphragm. This is a critical illness ICU patient. Right here, you recognize the normal striation of muscle fibers, right here in a higher magnification. And in the diaphragm of these critically ill patients, there are areas where the muscle appears completely destroyed. Sarcomeric disruption. We don't know exactly how it develops, but it is pretty consistent, actually. Also, we have found that in the diaphragm of these patients, the pressure generating capacity at the fiber level for both slow twitch and fast twitch fibers is decreased in compared to non-ICU patients. So critical illness has an impact on the diaphragm. And in fact, this has resulted in 2 review papers by a broad group of experts that provide some advice for, in addition to lung protective ventilation, clinical strategies for diaphragm protective ventilation. So I think as clinicians, we're starting to recognize that the diaphragm plays an important role and is affected by critical illness and mechanical ventilation. So when you should talk about COVID, is it important to look at diaphragm weakness specifically in COVID-19 patients? Well, there are some risk factors, I guess. So this is a large study from the Netherlands, from the Provence COVID investigators. And they show, at least for the Netherlands, the mean duration of mechanical ventilation for patients admitted for COVID is 2.5 weeks. And I think that's in line with many other data published so far. Reintubation is more or less similar compared to non-COVID ICU patients. Oh, I think we're missing one slide. Okay, doesn't matter. And also, if we look at the 1-year outcome in hospital survivors, a large study published last week in The Lancet from a Chinese group, they demonstrated that after 6 months, 74% of the patients experience muscle weakness, and at 12 months, still 22% of the patients experience muscle weakness. And I'm actually missing one slide, but there is another study from the Netherlands, from Maastricht, that demonstrates that 3 months after ICU discharge, around 40% of the patients experience dyspnea. And this is not directly correlated to lung function or CT. And I'm not saying here that all of this results from diaphragm weakness, but it's intriguing. And at least it motivated us to look in some detail on the impact of COVID-19 on the diaphragm. It's a multi-center study by our Chinese PhD student Zonghua Shi and the group of Koen Ottenheim. So we obtained biopsies of the diaphragm of patients that died of COVID in the ICU and non-COVID-19 patients. So this is like the median duration of mechanical ventilation was 12 days, ICU stay 13 to 12 days, not different between the two groups. And the first question was, because that was not known, is there expression of the ACE2 receptor in diaphragm muscle? Because as far as I understood, but from the first talk we learned it might be a little bit different, but as far as I understood, you need the ACE2 receptor to internalize the virus. And indeed, looking at the mRNA level, both for control ICU patients and COVID-19 patients, we found evidence for the ACE2 receptor. And immunostaining actually demonstrated, right here in red, that it was expressed at the sarcolemma. So these data at least showed for the first time that there is expression of the ACE2 receptor in the respiratory muscles of our patients. Secondly, we looked if there was evidence for viral infiltration for SARS-CoV-2 into the diaphragm of these patients. And obviously, that's not the case for the control ICU patients, but at least in 4 out of 26 patients, we did find viral particles inside the diaphragm fibers of these patients. You might say this is a little bit disappointing, only in 4 out of 26 patients, but remember, some of these patients were in the ICU for quite some long time, and they might already have cleared the virus. But now we have evidence that the virus infiltrates into the diaphragm of ICU patients. And what was also remarkable is the increase in fibrotic tissue in the diaphragm. So this is a control ICU patient, this is a representative COVID ICU patient, and red stains collagen fibers. And it's quite easy to see that's a huge increase in fibrosis in the diaphragm of these patients. To better understand this, we did quite extensive RNA sequencing, and we found that almost 600 genes are differentially regulated in the diaphragm of COVID-19 compared to non-COVID-19 ICU patients. And what was especially, well, at least interesting to see, that there was, right here, that there was an upregulation, especially of genes involved in inflammation and fibrosis. Actually, we did not see a difference in inflammatory markers, lymphocytes, macrophages, and so on. And these are data that were actually published yesterday or the day before yesterday, where we looked into a little bit more detail what was going on at the histological level. And actually what we found in the diaphragm of the COVID-19 patients was actually a centrally located nuclei in the diaphragm fibers. So normally fibers would be located at the periphery of the muscle fiber, but in these COVID patients were actually located more centrally and located in like trains. And this is something that we have never seen before in hundreds of diaphragm biopsies of critically ill patients. And something else that was remarkable is the presence of fiber splitting. So right here, we don't know exactly what it means, but it's a very remarkable finding actually. But you have to be careful because it's a relatively small number of patients. We did not find that in non-diaphragm muscle fibers, so in peripheral muscle fibers. Well, you could say this is all in patients that deceased because of COVID. So right now we have an ongoing study where we use quite sophisticated MRI for the contrast-enhanced MRI to look for the presence of fibrosis in the diaphragm. So the diaphragm is located right here, and here in ventilated COVID patients. And this is quite an intense and laborsome study, and unfortunately, I cannot present you the data right now because it's an ongoing study, but it would be very interesting to see if there is indeed fibrosis in patients surviving COVID-19 and if it has a relationship with clinical outcome. So what I've shown you for COVID in the diaphragm is the presence of viral infiltration, activation of pro-fibrotic pathways, and specific myopathic changes not described in other patients with critical illness, diaphragm weakness. So then an important question is if, but I'm still careful, if COVID causes diaphragm weakness, is there anything we can do? Now, of course, we do not have trials at this moment, but if we go back to the study by Huang, the Wuhan paper published recently in Lancet, what they actually demonstrate is that the use of corticosteroids was associated with fatigue and muscle weakness at 6 and 12 months after discharge. It's an interesting observation. And the other thing we can do, and it's the same we do in non-COVID ICU patients with severe diaphragm weakness, is inspiratory muscle training. I'm sure you are aware of this study published like 10 or 11 years ago, where patients difficult to wean from mechanical ventilation were subjected to inspiratory muscle training or sham training, and what they actually demonstrated that in patients subjected to inspiratory muscle training, strength of the diaphragm increased, but not in the control group, and the chance of being weaned from mechanical ventilation was increased. And this is a pilot study published recently. It's a very small study, but still interesting, where they randomized patients with COVID to IMT or control. These were all patients that were just weaned from mechanical ventilation, so being extubated, and IMT was provided 2 sessions per day, 30 minutes each, for 2 weeks. So right here, the forced vital capacity. As you know, the vital capacity of the lung does not only depend on lung characteristics, but requires a deep inspiration, so depends on respiratory muscle activity. And what they actually found that not in the control group, but in the IMT group, there was a slight increase in the forced vital capacity. Also, dyspnea scores decreased in the group subjected to inspiratory muscle training, and 6-minute walking distance increased. Which is a little bit disappointing and surprising is that it did not report maximum inspiratory pressure or any other function of the diaphragm in this study. So to conclude, Mr. Chairman, I think what I've shown you is that we do have evidence right now that there is SARS-CoV-2 infiltration in the diaphragm associated with fibrosis and myopathic changes not observed in general ICU patients. To be honest, the clinical impact is unknown. I mean, it would be interesting to see if it plays a role in difficult weaning from mechanical ventilation, if it plays a role in long-term sequelae that are well known for our COVID patients. And further, I mean, risk factors, treatment has to be investigated, obviously. Thank you very much.
Thank you, Leo. We have time for a quick question. So does these changes in the histological structure correspond to any difference in the strength or endurance of the diaphragm of COVID as compared to other pneumonia patients? Do you have any other functional test that can be done at the bedside that was compared?
No, at this time we do not have these data. I mean, we have all these patients now in the post-ICU outpatient clinic, where we do actually assess inspiratory pressures and other function of the diaphragm, but we don't have the data available right now. And we want to correlate those, of course, with the changes we're going to report on the MRI. That's right.
Only two very quick questions. The first one, in your paper in JAMA Internal Medicine, you compared the COVID-19 and non-COVID-19 patients. Was there, I didn't see from the table, was there a difference in the use of neuromuscular blockers in the two groups? And the second is, so do you think that, for example, bedside ultrasonographic assessment of diaphragm function can be useful in these patients?
So the answer to the first question is no, there was no difference in the use of neuromuscular blockers. And the second, if we could use ultrasound, I think there's some studies ongoing right now to look at differences in density with ultrasound, but I think it requires further validation. I mean, there's a study by the group from Toronto that reported differences in density of the diaphragm muscles in COVID-19 patients, but I think it's very preliminary, and before we can draw any conclusions, we first need to, in one way or another, correlate that to histology of the diaphragm or more advanced imaging, actually. So, no, today we do not have those data.
Thanks.
Okay.
So thank you, Leo, and we move on to the last speaker, who is Professor Annan, and he will talk about the volatilomic I see there in COVID-19. Thank you.
Thank you, Mr. Chairman. Good morning, dear colleagues. So, my task this morning is going to be to discuss a little bit about volatile compounds during COVID-19 and what we can do with that. So, here I'm a conflict of interest disclosure. So basically, medicine is based on investigating the physiological systems and disease through sampling the body by different ways. So, for example, looking at blood glucose level in the blood is helpful to the diagnosis of diabetes and to the monitoring of patients. Exhaled air is also something that is already sampled in routine in many cases. For example, police use exhaled air to diagnose that people have taken alcohol or some drugs. Or in the operating room, you're monitoring EtCO2 in many of your patients. So this exhaled air is providing a lot of information that so far might not have focused attention of most ICU physicians. Yet it is very easy to assess it. It's non-invasive, and you can get the information in real time. So that it's easy in theory. It might be more complex in practice in the ICU if you want to get reliable information. So basically, at the moment, that needs complex devices. Like, for example, the one we used in our study of 40 ICU patients with COVID-19. So the proton transfer reaction, quadrupole, time of flight, mass spectrometer was connected to ICU patients directly to the intubation tube. and remain on place for about 10 days for continuous measurements. So that allowed us to get real-time recording of any single particles that was exhaled during patient's course for 10 days. And we used the PTR-MS packages to analyze the data, which is a complex process, as briefly summarized in these slides. So you can see that there are a number of steps from the raw data to get the final peak table. So, for example, you have to first discriminate between the ambient air and the air exhaled by the patient. And also you have to analyze within specific range for MZ values and calculate, compute the sum of peaks that you identified within a specific range of value, and then you have to transform mathematically transform these curves with deconvolution techniques and so on. So basically, there are complex mechanisms and complex mathematical models that allow to translate any single particle that is exhaled continuously to present them graphically and then to analyze them quantitatively. So that is what we did, and I'm going to briefly summarize our preliminary data. So we investigated concomitantly during the first wave non-COVID ARDS that were managed in the non-COVID ICU, and the COVID and patients were admitted for COVID-19 ARDS. So the two populations were roughly similar, but unsurprisingly, one can see that patients with COVID-19 were more likely to be managed with higher PEEP than the non-COVID-19 patients, and also required higher FiO2 while receiving similar VT management. So we need to first get rid of any factors that may confound the analysis of exhaled air, and in particular the mechanical ventilation itself and the effect of the mechanical ventilation. So here I presented the score plot from the principal component analysis for the main 4 volatile compounds that we could identify, and we checked that neither the tidal volume nor the respiratory rate were influencing the values and the concentration of this compound in exhaled air. So one can see, for example, here that for the tidal volume for any of these 4 volatile compounds, the tidal volume was influencing their concentrations, and likewise the CRP as a marker of a systemic inflammation also was not related or did not influence the value of air concentrations for these compounds. That was also true for body temperature and also for the stay in the ICU before starting the measurements in the patients. So PEEP and respiratory rate, again, were markedly higher in patients with COVID-19 compared to non-COVID ARDS. And so PEEP actually was the effect of PEEP was investigated by moving the PEEP from 5 to 17.5, and for each individual volatile compound of interest, one can see here that there was no influence of PEEP value on the concentration of these compounds. Similarly, respiratory rate did not significantly influence the concentration of these compounds in the exhaled air. So I think this was very important to be checked before indeed analyzing the capacity of these compounds to discriminate between COVID patients and non-COVID patients with ARDS. So, and that again was here the crude findings using the principal component analysis in the left-hand side and orthogonal partial least squares discriminant analysis in the right-hand side. One can see in blue dots the non-COVID-19 patients, in red crosses the COVID-19 patients, and there were a very nice and clear separation in between the two groups with no overlap in between the two groups. So the four volatile compounds were found in the exhaled air of these patients in a discriminant manner between the COVID-19 and the non-COVID-19 patients. Here are shown the ROC curves for the models that classify patients with or without COVID-19 ARDS. So on the left, that the complete model, the model using all the metabolites found, and there were thousands of metabolites found in the exhaled air. So, and there was 3 machine learning algorithms to check the accuracy of this complete model. And one can see that the accuracy was high. It was 93% for all the 3 machine learning algorithms. And after internal cross-validation, one can see that the sensitivity and the specificity were really high. And when we move to the 4 volatile compound of interest, one can see that we did not lose much information from the complete model. And the accuracy remained high, around 90% again, ranging from 89% to 93%, and the sensitivity and specificity also remained very high. So, as I mentioned in my first slide, so these biomarkers are useful not only for the diagnosis and the initial discrimination of the patients, but also for monitoring the patient. So in the upper graph, you have the first acquisition per patient for the 4 volatile compound of interest, and one can see the marked discrimination in between the COVID-19 patients in red box compared to the non-COVID ARDS in blue box, in whom patients, the volatile compounds were almost never detectable. In the bottom graphs, one can see the time course for the volatile compound, as we were monitoring them over time for 10 days. And one can see again, so these are individual plots, and the line here is the least the fixed effect of a fixed model for each group. And so one can see that the discrimination between the two groups is really sustained over at least over 10 days following ARDS onset in these patients, which is remarkable for biomarkers. So other potential confounding factors for the difference in between the two groups could have been severity of illness. So we checked this through the SAPS-2 score and SOFA score that did not correlate it with the concentration of this volatile compound. And also we found that there was no correlation with viral load measures in the bronchoalveolar lavage of these patients. So to conclude, breath analysis can discriminate between patients with or without COVID-19 related ARDS. The VOC breath print to identify COVID-19 requires invasive mechanical ventilation with high sensitivity, in patients requiring invasive mechanical with high sensitivity and specificity. The 4 most prominent volatile compounds in the patients are now being identified using their MZ values. So, and these 4, among these 4 compounds, one is never present in human. That means that this one is very likely to come from the virus itself or from some interaction between the virus and the body, because that compound is never found in human bodies. And also non-anal is a compound that belongs to cell's membrane and that is released after the breakdown of the cell membrane after an oxidative stress, for example. So we are now, our next step are, we first have confirmed in ambulatory patients with or without COVID-19 patients that these 4 volatile compounds are discriminant. So this not only for ARDS patients in the ICU, and we are now developing electronic nose that will help to do this very easy everywhere. And for example, the government are funding us because they are interested to have such electronic noise, for example, at the entrance of a subway or at the entrance of theaters where people can easily check their COVID-19 status. Thank you very much.
Thank you. Thanks, Professor Anand. Are there questions from the floor? If not, only one curiosity. How did you said that this is not correlated with viral load. How did you assess viral load?
Yeah, we measure it in the bronchoalveolar lavage of the patients and by PCR.
Ah, okay, thank you. So, if there are no other questions, thank you very much for attending the session. Thanks to all the speakers, and enjoy the rest of the Congress. Thank you.
Thank you.